We are live now, doctor.
Okay, good. I request Dr. Naresh sir to please start the meeting with the welcome address and the introductory speech. Dr. Naresh sir, please.
Yeah, thank you, Chittaranjan. This is one more episode of the felicitation for the winners of the imaging. So for the last 4 years, close to 4 years, we have been having this imaging session month after month without a break, and the felicitation is happening at a regular interval. So we encourage all the people to contribute more to this imaging. As I keep telling, there is no copyright issue involved. In case if they want to withdraw the image, in case if it is published elsewhere, it is always done, and we don't store the images in any of our website unless otherwise it's warranted. And today also we are going to have a esteemed panel which will be introduced by Chittaranjan, and I would like to congratulate all the winners who will be facilitated today. Over to you, Chittaranjan.
Okay. Thank you, Dr. Naresh sir. And in this session, we will be felicitating the winners for the months of July, August, and September 2025. And we have a very eminent retina specialist of national and international repute as panel this evening. We have Dr. Dhanusri Ratra, Dr. Parveen Sen, Dr. Tapasanjan Padi, and Dr. Nishikant Borse. They don't need any introduction at all. They are very well-known figures in the field of vitreoretina. And straight away we'll go to the winners for the month of July 2025, and the third prize goes to Dr. Anujit Paul. Dr. Anujit is a VR and cataract consultant in BVI Foundation, Kolkata, and this is the award-winning image which he have titled as "Drops from Heaven," a premacular hemorrhage, sub-ILM probably, and he has done YAG membranotomy and very nice outcome. This is the text Dr. Anujit has given, and may I request Dr. Anujit to please speak a few words about the award-winning image. Dr. Anujit.
Thank you so much, sir. Thank you to the committee for recognizing this image. About the image, this is, I think, these are cases that do come to our OPD quite often. And just after membranotomy, I noticed that sometimes the patient is uncooperative, but in this case, the patient was very cooperative, and I could notice the blood ooze out into the vitreous. And suddenly it struck me that the pattern in which the blood is coming out, maybe we can get a fundus photograph of it. And then immediately the patient was shifted between 15 to 30 seconds, and we took multiple images, and this is a curated montage. I think these are 5 images that were taken and together stitched together. And this is not edited at all, except for the one that came out of the machine itself. And to me, it looked like something which is quite interesting. It raises, it's like a picture telling 1,000 words. And therefore, I submitted it. And thank you so much for recognizing the image.
Great. Congratulations, Anujit. And may I request our panel, any of our panel to take this image for further discussion? Any of our panel members?
So Anujit, you had used YAG hyaluronic?
Yes, sir.
Okay. And what did you do after this once the blood was drained?
So we followed the patient up. I think at the end of 3 months, the patient presented with counting fingers, and at the end of 3 months, the patient had 6/9 vision. So the patient is currently also under follow-up and doing quite well, sir.
What was the primary cause here? Do you know?
No, sir. This was actually taken in a peripheral center. So we got very little time to follow up the patient in terms of history. So not sure about the primary cause.
Okay.
Anujit, which lens did you use to do this YAG laser?
Sir, I use the Abraham lens only.
Okay.
If I could ask one more question, Anujit, did you try to differentiate on OCT whether it was a sub-ILM or a sub-hyaloid hemorrhage?
Yes, yes, ma'am. I tried to differentiate it. It looked like a sub-ILM hemorrhage to some extent. So we did have a discussion in amongst us young ophthalmologists regarding what it could be, but I think it is a sub-ILM hemorrhage because of the halo.
Okay.
Chittaranjan,
Yes, sir.
hello.
Is that high?
Yes,
No,
sir.
no, yeah. So I think a similar picture was made by us, which is in the page of the cover of the current edition of Payment. Hello.
Yeah. Similar image, sir. You have similar
Yeah.
image published in AJO also, American Journal of Ophthalmology, and
So
one in Payment cover page. So this one also Anujit has taken nicely. We also thank the optometrist or whoever has taken
Yes,
nice
yes. I would
montage.
definitely acknowledge. I would definitely acknowledge the entire team, sir.
the thing
Yes,
is,
sir.
this is a typical sub-ILM.
Yeah.
First premacular hemorrhage is basically sub-ILM. Once the hyalotomy has been done, then it has come into the, ILM was broken, then it has come into the subhyaloid space, number one. I think that was
Correct.
our publication. And maybe
Yes.
once the blood was drained completely, we can see the ILM, which will appear like a sort of a pseudo CSR-like picture in these cases. Maybe if we would have
Yes.
waited for 1 or 2 hours, we could have seen that potential space between the ILM and the retina, which would have appeared like a CSR.
Yes, sir.
I think
Just
superiorly
one.
you can see this as well.
Yes,
Yes.
yes.
This
Exactly.
one.
Yeah.
So correctly, what Parveen ma'am is saying, there is some description about arcus retinalis by one publication by Vinod Agrawal sir and Neha madam. So this white color, they are saying that it's arcus retinalis and mostly found in sub ILM vis-a-vis the sub this thing hyaloid hemorrhage. So maybe that one also can be one of the biomarkers, fundus-based biomarkers. So good, nice discussion we had on this, and again congratulations, Anujit. He wins certificate and 2,000 rupees. So party in BBI Foundation, Kolkata. Anujit is very active in EOC.
Thank you. Thank you
Okay,
so much, sir. Thank you, sir.
thank you. So with this, we move to the second winner, and the second prize goes to Dr. Vignesh. Dr. Vignesh has completed his research fellowship and long-term VR fellowship in Arvind Hospital, Madurai, and currently he is a consultant, VR consultant there. And this is the award-winning image, which he has given the title "Bear with the Bear Hiding in Plain Sight." This is a picture of Charpy, and this is the description he has given. May I request Vignesh to please describe this image? Dr. Vignesh, please.
Thank you, sir. Thanks to VRSI for this opportunity. So the patient was a 23-year-old male. He presented with complaints of left eye diminution of vision since childhood. So on refraction, he was diagnosed to have bilateral hypermetropia, and left eye was amblyopic with bilateral extensive chirpy lesions. So when patient is also a known case of familial adenomatous polyposis who was on regular follow-up with a gastroenterologist. So we just advised the patient for a yearly follow-up and sent him.
So any follow-up the patient has come, Vignesh, or we
No,
are yet
sir.
to get
This patient is actually from Rajasthan, sir. So he had come here for some pilgrimage. So he heard about the hospital and he came here, sir. Just for the amblyopia, to ask if anything can be done for his left eye amblyopia, he had come, and this incidentally we saw the fundus image, sir.
Great. So you have taken this image in Aiden camera, right?
Yes, sir. Yes, sir.
Okay. So nice photo. May I request our panel members, Subhadra Madam, Unni sir, any comments on this image, or how frequently do we see really this familial adenomatous polyposis in these patients, or how kind of serious we should be about that systemic disease if we get a picture like this? Tapas sir.
Yeah, I think we
Yeah,
should
ma'am.
be very serious because this is something that we can pick up. But it would have been interesting to know how was the other eye? Was the other eye also having same lesions or was it unilateral?
No, ma'am. It was bilateral, ma'am. The other eye also had a very similar picture, ma'am.
Yeah, sometimes we can have it unilateral also. But if it is bilateral, then we are more concerned. And yes, they need regular, endoscopy or whatever for checking your GI tract. because this is the
Yeah.
only way to sort of do a prophylactic screening and save them from, because if you ask them, they will have history of people dying in the family due to undetected or late detected cancers, and these cancers can be treated, although they do have multiple recurrences, but at least something can be done early enough, and they are sensitized to get this done. So I think, yeah, but it is like every patient who has these lesions may not have familial polyposis, but this is an indicator. The association has been very well documented in literature. The color of this looks little different from what we normally see, because the Edion gives little more darker picture. So one
Yeah.
should be able to recognize different colors, because sometimes the lesions may not look the same. Sometimes they may just look like artifacts. So I think the what fundus photo we have taken, that would be nice.
Yeah.
So, Vignesh, if I can ask you, what would you tell the audience that for every case of chirpy, would you suspect underlying familial polyposis, or there are some specific features which tell you that these cases may be more liable to develop? Because sometimes we do see chirpy very often, but would you send or expect a risk of cancer in all cases? What are the biomarkers which would tell you that risk is high in these cases?
Ma'am, not all patients we send usually for a gastroenterologist opinion, ma'am. This patient, the lesions were multiple and bilateral. So, to be fair, honest, I have never seen these many lesions in all the other patients that I have seen. So this patient, since there were extensive lesions, I asked him. He said that he's already on a regular follow-up, and hence I just asked him to follow up regularly with a gastroenterologist, which I felt was more important than for the ophthalmology part.
Yeah, correct. So
Another thing is
the
like
two features you mentioned, bilaterality and widespread multiple lesions. Solitary chirpy may actually not be so much of association with the FAP.
yeah.
So it is the multiple and bilateral that you
In
have to.
young males, another
Yeah.
indication if young males present with kind of picture. And also sometimes you see these chirpy lesions, they are multiple and they are particular shape. They are just like coma shape with a small tail attached to it. If you see that kind of lesions, they are definitely familial adenomatosis. So for those patients, you have to go in for a detailed exam.
Sometimes differential may be something like a torpedo retinopathy, but sometimes the torpedo retinopathy is some more of a unifocal kind of a lesion,
Focal and single solitary.
single solitary lesion. So it is that multiple lesions and deep-seated, and maybe OCT also you can do, but with such multiple lesions, I think we are in no doubt as to what we are dealing with.
Sometimes the margin can be irregular and that fish-tail pattern of hypopigmentation that we see with torpedo. So that can be also the suspicion when you have this, in addition to the bilateral and multiple mid-peripheral lesions, one should investigate for FAP.
Unni sir, you wanted to add anything? Unni sir?
Nothing much. See, I just want to add a general point, being that as retina specialists, it comes a little bit natural for us to diagnosis. But 2 points that have to be sensitized is that these are the lesions that even general ophthalmologists who do a good indirect they should not just leave it as RP changes and just leave the patient off. The second point being that since this is a good point of the importance of good retinal imaging, doing a good indirect, because all the lesions are outside the arcades. A 90D examination cursory would miss all these things. And why is this important for the general ophthalmologist? Because then, because of the association of FAP, that is a point. So, contests like this, meetings like this, they have to highlight the importance of these lesions, so that when a general ophthalmologist logs in, they understand why it is important to diagnose a multiple chirpy.
Another thing is like you should take a red-free photograph also along with this, which will more clearly highlight these lesions.
Correct. So point is very well taken. Great points by our panel. So basically, we have this fundus biomarker these Charpy lesions, which should sensitize us, or rather, they should open our brain to think about the systemic, very serious conditions. And also the comet tail or tapering tail kind of lesions, if they are present, they should even increase the suspicion more. So thank you, everyone. And just one point more to Vignesh, because you have also Claris with you, as Subhadra Madam rightly told, Eden gives a little darkish background. So if you have taken in Claris also, then it will be little more contrasting, better image. So anyway, congratulations to you, and Vignesh wins certificate and 3,000 rupees for this.
Thank you, sir. Thank you.
Thank you, Vignesh. So with this comes to the first winner for the month of July, is Dr. Suchitra Biswal. Dr. Suchitra is a VR and UVA consultant in Sankarai Hospital, Simoga, and this is the beautiful image which she has taken, and she has captioned it as a cartography of emptiness. And this is the description that Suchitra has given. So with this image also, I think Suchitra has won the best prize in Retina Imaging Congress competition recently held in the month of July in Trivandrum, organized by Chaitanya Hospital. So double congratulations, Suchitra. So please explain about this image.
Good evening, one and all. Thank you for the opportunity. This is a case of a 40-year-old gentleman with a visual acuity of 4/60 in the left eye. He was a known case of left eye ischemic central retinal vein occlusion, and he was treated earlier with intravitreal anti-VEGF and pan-retinal photocoagulation. This is a 12 into 12 mm reverse OCTA image captured with Topcon DRI Triton OCT. In the reverse OCTA image, the flow signals are represented in dark and the flow void areas are represented in the white. This image shows the extensive flow void area with the presence of collaterals and neovascularization of the disc. This indicates the need for the additional photocoagulations.
Great, nice image, Suchitra. So we'll come to our panel directly. Obviously, a beautiful image. Of course, very guarded prognosis for the patient. But image and see the presence of mind. She has taken the inverse image. She has taken. So we'll come to our panelist. Any comment on this? Any of our panel, please.
So Suchitra, do you do this inverse for most of your patients after the octa to pick up lesions, or this was just a one in wanted?
So in every image, we can get this reverse image. So, like there is an option in which they will have a 3 options: color image, reverse image, and black and white image.
So do you regularly use a reverse pattern to find out lesions more effectively?
No, sir. It just gives the different presentation, but it doesn't really add in finding a new finding or which we are missing in the regular OCTs. Yes.
Suchitra is trying to say that when she wants to win an award like this, she will take the image. Otherwise, that management does not change with the image. That's right, Suchitra?
Yes, so the management doesn't change with the reverse OCTA image.
I have
Sir
only
wants to
one
say.
question, Suchitra. Why did you name it cartography?
My intention of to title it as cartography of emptiness, it means that there is a map with an empty road. So this picture depicts that the map is there, but the roads are empty. The capillaries are not there. It gives an appearance of deserted retina, like.
Okay, so basically just I wanted to understand cartography is the art of making maps. So you have likened the retinal vasculature to a crisscross of roads and features on map. So this is a cartography. Anyway, nice title. Thank you.
Thank you, Mom.
So I just want to add one small point about the reverse imaging, not in this. It's not that reverse imaging is not useful. The most important, one of the most important of reverse imaging is reversing the OCT image. Reversing the OCT image from white on black to black on white gives the better definition, especially of the outer retinal layers. Just a small additional point, nothing to do with this image, but reversing the image has some value in certain conditions. Yeah.
So I have a question to Suchitra. Actually, I have tried this reverse imaging in this very much ischemic central ischemic patients, but the artifacts come very significant artifact. Your image is devoid of artifacts and very clear image. So is it any tips you want to give to capture OCTA images in the severely ischemic eyes?
So what I would like to say is the getting a good image is mainly depends on the patient cooperation. If he's very cooperative, then we can capture a good image.
I'd like to add a point there.
Please.
Whatever artifact you get on the regular image will be converted to black on the reverse. There is no new artifact formation. If you see beneath the disc, you see some black lines. On the other, it would be white lines. So it is just that they are more prominent. So there is no post-processing change in
No,
the
sir,
artifact.
is there anything like their fixation is poor because of this ischemia?
No, the
Anything
image is
there?
a regular OCT. This is a regular OCTA taken, and only
Okay.
the pixels are changed white to black, black to white. That is the only thing that happens in reverse imaging. It's a post-processing thing. So whatever you capture, artifact you capture on regular thing, it is just converted from white on a black background to black on a white background.
Correct. So great points with this image, and again congratulations, Suchitra. So she wins the first prize certificate and 5,000 rupees. So good, congratulations, Suchitra. So with this, we'll move to the August month winners, and the third prize goes to Dr. Dr. Deepanshu is vitreoretina consultant in Retina Specialty Hospital in Indore, and this is the beautiful image of wide field glimpse of AROP, for which he has won the award, and this is the description he has given Deepanshu. May I request Dr. Deepanshu to please say a few words about this image.
Thank you, Jitendra sir and VRSI for acknowledging this image. So this was a routine day of a screening of ROP. We went for a peripheral SNCU screening and we found this child to have on 21st day of birth. The child was 32 weaker with 1550 grams of birth weight. And he had this plus disease with flat neovascular network on the avascular and vascular retina, between the retina. And we diagnosed this as zone 1 aggressive retinopathy of prematurity and advised the child intravitreal anti-VEGF, followed by the child was subjected to LIO. So since the image, we were able to capture the image with Nidec Mirante, and since the image quality was we found to be very clear and crisp, the network can be very well. It was very well depicted. So we plan to submit in the VRSI image competitions.
So before I go to Tapas sir and Subhadra madam, you took this image in Nidec Mirante.
Yes, sir.
Okay, very clear image, very nice.
Very clear image, sir, actually.
Yeah. So, Dr. Tapas and Subhadra madam, your comments on this.
Yeah.
So I'm sorry, I don't know about this camera. This is a contact or non-contact, and it is done in the field where the patient was, or it was done when the patient came to the center?
Yeah,
patient non-contact non-contact fundus camera only, and patient had come to for the intravitreal Avastin and for the treatment. So that time, like before injecting, we took this picture actually in flying baby position, as we usually take for Claris
like
or
Optos,
yeah.
Madam, flying baby position they have taken his.
We have this Mirante system with us, but it is unlike Optos. It is a little difficult than Optos, which is why I think probably we should congratulate him on getting it on Mirante. Because here, your baby has to put the face you would have to put on the chin rest. Without that,
As in the support staff had held the
they
face
have
of
to
the
really,
baby.
and that also with the speculum in place.
Yes, ma'am.
So, yeah, it's quite difficult.
So I just want to highlight that,
Technicians were
sometimes when we have tried to publish some of these images, some reviewers have questioned, that you are being you're terrorizing that baby, or you're compromising their life or something. But I just want to highlight that there is no compromise. We can put them in flying baby position. We can do OCTs, we can do fundus photos, and this just highlights that very nice pictures can come, because then we can show them to the parents. We can also follow up the babies. So there is no reason for anybody to feel that if they don't have a pediatric camera or a red cam or a 4S, that they cannot take pictures. Today, with various ways, whether it is cell phone 20D or with these adult cameras, all of us should be in a position, any retina person should be in a position to safely take pictures of these babies. There's no issue putting the speculum, holding the baby, making sure baby is well fed, not hungry, babies well wrapped, they're not cold, and they are not aspirating, and we can take pictures, we can do OCT, we are also doing now oral fluorescein. Even with the feeding tube in place, we are able to do fluorescein within 5 minutes. So I think all these technologies are there now in our hands. They are quite safe. All of us should learn how to take these pictures. So congratulations, I'm so happy that you have taken this picture. Sometimes people will ask, is it zone 1? Is it posterior zone 2? And then, about the plus, as we rightly see in this picture, that the new classification of plus is like, even if 2 vessels are involved, initially it used to be 4 vessels. So here we see the disease somehow is more, at least in the picture, it seems it's more in the upper part than in the lower part.
Yes,
But that's fine. It doesn't matter, as long as 2 vessels or more are dilated tortuous, we can take them. About zone 1, zone 2, you put circles, you measure. Again, it's not important. What is important is the pattern of vessels, as you have rightly shown. If they are looped, if they are forming shunts, then these are sort of AROP, and they should be treated as such. Some parts of this image may look like a small area stage, so what we call as hybrid. So ICROP has not accepted hybrid, but yeah, in India we do recognize these hybrid cases because of varying levels of oxygenation and other childcare practices and maternal factors. So we should not sort of fight on that. Whatever is there, we can see these are abnormal vessels, they are shunting vessels, there is dilatation and tortuosity, and that is enough to decide that this is serious and this needs immediate treatment with injection, laser, whatever is available.
I
And
just
we have to take care of the
madam.
systemic.
Thank you very much, madam. Tapas, sir.
Yeah, I quickly, Dipanshu, just take you to the publication on by the PGI group in 2021, 2020, 2011 in BJO. So this is the classical of pattern 2 hybrid ROP. You can see that the dilatation tortuosity is not that great. The arteries and
only in the upper
veins,
half, sir. Yes, sir.
till you can, they are not, they look alike. And in the pattern 2, the early reach starts within the vascularized retina. So in addition to the arteriovenous shunt at the multiple level. Typically, these are the type of ROP that is seen in little bit bigger babies, and they fall a midway between AROP, where the progression is very fast, versus staged ROP. They are worse than the staged ROP, but better than your aggressive ROP.
The eye did not have the plus disease at this point. Only in this eye, only upper half, we felt that dilatation and tortuosity. And since it was a peripheral patient, sir, we did not want to lose the child because parents were
No,
not
sure.
well educated.
This would again qualify for the plus disease, but then again there is an important catch here. You see, if you look at it, the tortuosity is very, very prominent at the periphery. So
Yes, sir.
most of the cases, the tortuosity first starts in the in the shunt, then it progresses towards the posterior pole.
Yes, sir.
Great. So
Thank you.
nice points again. Congratulations, Dipanshu. He wins 2,000 rupees.
Thank you.
So Dipanshu has to give a treat to the support staff who really helped him in taking the image. So good. Now we come to the second winner,
Thank you, sir.
Dr. Aditi Anil Kumar. Congratulations, Dr. Aditi. Dr. Aditi is VR consultant in Narayana Netralaya, Bangalore, and this is the award-winning image. The caption is Nebula on the North, and this is the description that Dr. Aditi has given for this. May I request Dr. Aditi to please describe this image?
Yeah, good evening all, and thank you VRSI for this acknowledgement. So this was a 40-year-old man who walked into the OPD without any known systemic illness and was found to have about the right eye, the other eye showed grade 2 hypertensive retinopathy. The left eye had vein occlusions in 2 quadrants and neovascularization of the disc. So just because it looked beautiful, so I thought of imaging it with an Solix Octa scan, and I looked at the on-fast image. You can also see the STBR view slightly showing up, and this is at the level of the posterior hyaloid vitreous, which is why it highlights the disc. And it looked like one of those galaxies, and I thought I'd name it Nebula on the Nerve for the poetry of it. And this patient, and so I checked the BP. It was around 200, 110 at that point. Young man. And then I had referred because I wanted to do an angio to look at, what all vascular changes are really happening, because clinically it was just this NVD and 2 sclerosed vessels. So he is currently under multiple subspecialty care because of renal issues and also cardiac issues. So I'm awaiting for a review of this patient. That's the story.
I think important is to go ahead and do your laser, otherwise he may bleed. So it will take time. Usually they have renal artery stenosis or something and other things, but I don't think one should wait for an angiogram. If he's not fit for angiogram, you already have the Octa. At least some parts of it can be treated. But yeah, they have very high risk of dying of MI. They can get cardiac arrest quite often. So that is what, saving the vision and saving the life.
Yes.
So great imaging, and
Point
that is
is
the
very
lesson.
well.
Patient cannot
Yeah.
undergo FFP. Doesn't matter on your Octa or even on your fundus photo. If you can document that there is a lesion which can bleed, then we are justified in sort of intervening, even while waiting more advanced imaging.
The
Thank
point is very well taken from Subhadra Madam. It's non-invasive test actually, and we should rather do PRP to save the vision and also save the life. And may I request Dhanasri Madam to please comment on this image. Dhanasri Madam. Nisikant sir, your comments please.
Yeah, so it's a beautiful image, and I totally agree with Subhadra madam. Many a times I have had patients where I have actually referred them to systemic evaluation, and I actually lost the patient in the systemic because they found so many problems. And then the patient came back to me after about 3 months, and by the time he had already got neovascular glaucoma because of the extensive BR view. So I do agree that we have to have a fine balance between saving the eye and saving the life, and not focusing only on one. And that was a great point made by ma'am. We should balance well.
So, Dr. Aditi, good picture, but you must always mention what slab you are taking whenever you have an Octa image. So
So
we all know what slab is it. You can tell it for the audience. What's
the 9 mm. So I did a montage of the 9 mm.
but what slab? Superficial, deep?
So this is at the vitreous, at the level of the posterior hyaloid. There was an option in an on-fast,
Exactly.
like I'd
You
mentioned.
must mention that you do look it at the level of the vitreoretinal interface, which is why this makes more sense, because these are vessels sprouting into the vitreous cavity.
Yeah.
So that must be mentioned, then only the whole thing becomes more relevant. And
Yeah.
of course, if you have to give an anti-VEGF, probably you may want a physician opinion before you give it. But if you have to do a laser, I don't think you need to send the patient out of the OPD You can finish the laser and then send the patient for physician examination.
But with 200 BP, I think little hesitant to do a laser. But yes, you can, wait for 3-4 days, let the BP come down, and other investigations carry on. But yeah, I think with 200 or 180 BP, it becomes difficult to do any intervention because patient can collapse sometimes.
In a
At
setup
least, at least start the treatment if the patient is not known taking treatment. So waiting for a week or so will not cause a problem. I think that is the correct way to record the BP, and that is more life threatening. Like if you do the laser and then in the night he has a stroke because of that high BP, then you are in trouble. So I think that is the correct approach. Get the things done, and because the treatment and its original cause may take some time. Also, we have to, when we send these patients to the physician, we have to mention that please reduce the blood pressure slowly. Because if they reduce it fast, then the other eye can get NA even. That we have seen that happening. They suddenly, so they have to reduce it slowly, but I think in a week's time, the patient would be in a little better position, and then we can do the laser and simultaneously continue the other investigations and treatment. So sometimes we have seen this, that because the dialogue and the communication was not very clear, the patient didn't come for 6 months, and then they come back with vitreous hemorrhage traction and say, why you didn't come? Then they say that, I was still controlling my BP, or was still controlling my sugar. So to explain that even if BP is little high or sugar is little high, laser can be done. Even if you are undergoing some treatment, laser can still be done. But yes, the treatment should be started, and then it can be done even while things are getting controlled. So that clear communication to the patient and to their doctor is very critical.
So the point is very well taken. Actually, we are dealing with a very serious eye condition and serious systemic condition, and we have to manage the both. And we have to collaborate with the systemic physician and take care of the both the life and the vision for the patient.
So in some cases we have also done that, patient is admitted in the physician's hospital, and we take our LIO, and on the bedside with their monitoring, we do the thing so that in case patient suffers something, they are there to handle it. So we need to see how we can facilitate both simultaneously. These are both things are very critical. We can't ignore one for the other. I had one patient who, he died the night I have done laser, and he had come from Vijayawada, and he was a diabetic patient. He was not aware of his systemic things. When I saw him, I have sent him to Apollo Hospital for checking the systemic things and told you come in 2 days. So he was staying with a relative. He had come from Vijayawada to Hyderabad, and they have diagnosed that he has nephropathy and protein loss and things like that. So they have started treatment, and then I have done laser, and that day night he has died. So after a few days, the son came, and he was very angry, and he told me that, you have killed my father. You'd gave some laser. He thought laser is something like radiation. And then I had to take him to the laser room, show it to him. And then I told him that, look, your father, who was a well-known person, has been under care of diabetic for so many years, diabetologist, but nobody got his kidney checked. I had his kidney checked. So I was really caring for your father more than what you or your doctors were caring for. And that is what then calmed him. And then he sort of touched my feet and said, thank you. I said, nobody had even worked up the patient, and I only worked up the patient. And, it's not the laser which killed him. It's the untreated kidney problem. Maybe some potassium was high or something. I don't know why he died in the night. But I was happy that, I had that paper which showed that I had worked up the patient and got him to the correct, management. So I think these are important lessons I learned over 35 years.
No, thank you very much, madam. These real life stories actually, this teaches a lot, and also the documentation part that you told, that is also very vital, very important. So agree. So congratulations again, Dr. Aditi, and she wins certificate and 3,000 rupees for this beautiful image. With this, we move to the first prize winner for the month of August. She is Dr. Manu Sharma. Dr. Manu Sharma is pursuing her MCH in Vitretina in PGI Chandigarh, and this is the beautiful image. Can you please see that the caption is very well matching with this? The snail cell appearance of cataract nigra in a fundal coloboma. May I request Dr. Manu to please describe this image?
So am I visible?
Yes, yes, yes. You can speak. You are audible.
Okay, sir. First of all, I want to thank my mentors for this opportunity. I want to thank my mentor, Dr. Diksha Katoj, under whose guidance I have done this surgery. So it was a 56-year-old female. She had history of blunt trauma 5 years back, but he didn't consult it anywhere. So she came to us with a high intraocular pressure and with vitreous hemorrhage. So we did ultrasound. There was a drop nucleus on the ultrasonography. So it is the intraoperative photograph we have taken when the vitreous hemorrhage was cleared, and there was a large coloboma. Over this, the black cataracta nigra was lying, and it was appearing like a snail shell. So it was we gave the title as a snail shell on moon appearance to this image. And we take it out with the phaco-frag black cataractous lens and complete the surgery.
Okay. So you told about the lens or something you put, or like how
No, sir. We left aphakic. Patient,
you
we
left
left
it?
aphakic. It was a iridofundal coloboma, already compromised, high intraocular pressure, so we didn't go for the
Was
secondary.
it a microcornea also? The cornea was micro.
No, sir. A microcornea was not there. It was a iridofundal coloboma only. Yeah.
Okay.
If you see
So,
carefully,
Yes.
then we can see that just at the edge of that black cataract, you can see complete cupping. You can see that the disc is also compromised. Sometimes it is difficult to see the disc cupping in coloboma eyes, but normal disc should be pink and small and triangular. Whenever there is cupping, you will see that it will become completely white. So you can see that color has changed to come. Of course, it's an intro picture, so we should not comment on this color because sometimes the bottle height may be high and that can blanch. But if we just see the disc appearance, we can make out that this is a glaucomatous cupping in that. Uh, so was that correct? I think she may not get much vision.
Ma'am, pressure was kept at 30 only. No pressure was raised during surgery. So
Yeah, but she has glaucomatous cupping,
yes,
right?
ma'am. Glucometers, her IOP was high because she was having old vitreous hemorrhage in the eye. So pressure was high. So disc might be glucomatous.
Manu, I have a question. So this case had a iris coloboma, is it?
Yes, sir. There was iris coloboma also.
And a B scan was done before?
Yes, sir. B scan was done. On B scan, there was a coloboma and a drop nucleus. We can see there the hyperreflective globular structure on ultrasonography.
You know, this type of cataract nigra are very much characteristic of coloboma
Yes, sir.
eyes.
Coloboma.
Sometimes they can be rock hard.
Yes,
And
it was
so
rock hard, sir. I was taking it
it is
out. There
very,
was
very
multiple
difficult.
the sieve-like things are formed when my phaco-frag was moving back and forth. It was
And
creating
only
sieves inside this black cataractus lens.
the advantage you had is it had there was no microcornea. So if
Yes.
the cornea is small and very high axial length, you will really trouble like anything
Yes, sir.
during surgery, and sometimes you might have to use PFCL to just float it up and then do the surgery.
Yes, sir. Even with the PFCL and the levitation is also very difficult sometimes. I have tried in one patient, but it is very difficult to levitate the nucleus. It gets stuck between the retina and the PFCL interface. Then again, we have to take out the PFCL. Again, we have to fill it again. It's very difficult to levitate the nucleus.
Yeah, that is for the very rare cases, but here you had a good corneal diameter, and if it is not very axial length is not very high, then carefully one can remove with the fragmatum. Then again, the small pieces that will fall within this colomatous cavity, that excavation would become very difficult to remove them out unless you just shake the eyeball, float it, and change it again and again. Finally, you remove all the pieces.
Yes, sir.
So, sir, I have one question. Naresh sir, I think if he is there, he has published one, couching, the role of couching in this era, where very extreme like microcornea, as Tapas sir was saying, surgically very, very difficult, challenging cases. And in those cases, what they have done, they have just put it back inside, and because of the collateral damage or something will happen, they have not removed. They have left it, and patient was ambulatory. Patient was doing his work, her work. So, any experience of our eminent panel on
So
that
we are
technique?
saying, so I had commented on that, don't do that. See what has happened to this patient. The pressure has risen. It may not happen immediately in 3 to 5 years. The IOP
Okay.
can go high, though not in all cases. So even in small corneas, we are now using endoscope to remove it where the view is not clear. But I think that with the modern, even now we have long size, instruments for eyes which are too long, even for 30 millimeter, 35 millimeter high myopic eyes, for macular hole and others. Now we have long sized forceps and all, so we can do that. Even if we don't have that, sometimes what we do is, as we said, PFCL, you fill it fully with PFCL, it will float. If you fill half, it will go to the side. Other thing one can do is, if we don't have that, you can lower the pressure. Once you lower the pressure, the globe becomes shorter. Okay, there's little risk of little choroidal happening, but that is another technique that I have used when I didn't have a long forceps or something. You can lower the pressure, the globe becomes shorter, and then you can reach them. It is difficult, but yeah, with newer techniques, I think couching we should really like. Okay, if it's an 85-year-old lady and then I do a couching, it's okay. But most of these patients are young. The lesson to learn is to do their cataract quite early. Many times the doctors are postponing the cataract, saying that, you have a very complicated eye, you may develop more complications. So they keep on postponing the cataract surgery till it becomes hard and becomes more difficult to remove. We should remove these cataracts when they are softer. Then, the risk of any complication happening is almost negligible.
Yeah, so point is well taken. Prevention is better than cure. So let us, operate the cataract for these eyes earlier, rather than landing up in all these difficult situations. So congratulations again, Dr. Manu, and yeah. So she wins 5,000 rupees and a certificate for this beautiful image. With this, we move to the month of September. The third prize goes to Dr. Bija Srikala. She is a VR fellow in Girdhara Institute, Kochi, and this is the image VKH, an autoimmune artist at work, for which she has won the prize. This is the description. I think she remembers it. May I request her, Dr. Srikala, to please tell something about this image.
Yes, sir. Thank you, Chitranjan sir and VRSI for the acknowledgement of this image. So this was a case of a 36-year-old gentleman who had presented to us with diminution of vision in both eyes since 3 days. And he had a history of fullness in the ears, and no other systemic manifestations were present. On examination, he had a visual acuity of 612 in the right eye and 6.9 in the left eye. Intraocular pressure was within normal limits, 16 in both the eyes, and anterior segment was within normal limits. No signs were present. So fundus showed this image with multiple serous detachments in both the eyes. So we usually take OCTs in such presentations, but with such huge choroidal undulations and serous pockets, we just tried a multicolor image which beautifully delineated all these SRF pockets on the posterior pole and the periphery. So this was kind of intriguing. So we have submitted this image for the VRSI.
Yeah, great image. May I request Parveen ma'am, Dhanasri ma'am to comment on this, especially the role of multicolor imaging. Yeah, obviously the image is beautiful over here. In addition to that, anything it adds to that in VK size?
Yeah, I think number one, I would say VKH is not as uncommon as we think it is. You will see it quite often in your regular practice. And I think this is one kind of uveitis where multimodal images is, I think, diagnostic. You actually don't need anything else to diagnose VKH other than a combination of your fundus photograph and OCT, and if at all, you can add fluorescein angiogram. So I think that actually completes the diagnosis, and you can start patient on treatment. So it's multimodal imaging for VKH is definitely needs to be highlighted. which you have done in your case. Congratulations.
Correct.
Srikala, this is a very interesting image that you have shown, and it was very nice of you to use the multicolor image to highlight these elevated areas with these, multicolor one, because otherwise sometimes, of course, here there are a lot of areas, but sometimes some subtle elevations can be missed if you have only a single 2D image. So this is nice that you have shown on the multicolor image, and I think the diagnosis here with the image is quite obvious, because you see so many of these serous elevations. So of course, probably you will be managing it with the help of the UVA specialist. But this is a very good image. Nice. It's congratulations on this prize.
Thank you. We actually had taken a color photo also, ma'am, which did not delineate this clearly, all these lesions. So we just tried a multicolor which highlighted all these small pockets.
Correct, exactly. And also with this Optos or whatever pseudo color images, sometimes you may miss these subtle elevations. So it was nice. But is this a wide field
55-degree, ma'am,
image?
yes. 55-degree.
You have done montage?
No, ma'am, not montage, ma'am. On Heidelberg, we have taken 55-degree lens, and this is a single image.
Okay, that's very nice. Very good.
Thank you.
Good. Again, congratulations, Vijay Srikala. And this is, the third prize. She wins 2,000 rupees and a certificate for this. Nice image. Congratulations. So with this, we move to the second winner. Again, second prize for Dr. Manu Sharma. So this is, again, see, very beautiful image. Marks on a tree appearance in chronic CSCR, CS caption. Can you please see over here? So see, as we have been discussing for the sake of viewers, I am telling over here, we are discussing the retinal science and some bit of philosophy over here also, and some artistic look, as we can see. So eyes, systemic things, and of course the documentation, legal part, the sympathetic or empathetic environment as described by Subhadra madam, artistic things, and philosophy, whatnot. So this imaging competition completes it all. So very nice image. May I request Dr. Manu to please describe about this image.
Thank you, sir. Actually, it was a 46 years old male with a chronic CSCR. This is actually a serendipitous pic. We asked the patient to undergo fundus fluorescent angiography, and this is the image created on Optos montage image. Our photographer has created a montage of the Optos fundus autofluorescence image. So we can see there are two words instead of one. Otherwise, their lesion is just the one thing, the one word in the center we can see, and there was gravitational tracts and areas of hypo and hyperautofluorescence. But this is a montage image, so it has given the reflection of the one bird. So they were appearing two birds on a branch appearance. So I was so fascinated at looking at this image, and I thought I should send this image to the VRSI image competition. So it was a chronic CSCR patient. And on fundus fluorescent angiography, it is visible as a bird looking at a half moon. Actually, on fundus fluorescent angiography, the disc was appearing as half moon, and the bird is staring at that. So that is also very beautiful.
So okay, you keep that for the next submission. You may get another
Yes.
award for that. Yeah. So may I request Nisikant sir for his comments on this, please?
So, it's very fantastic when, we are doing day-to-day imaging and we really don't pay attention to such things that come our way. Sometimes you can see an OCT on which you can just see a vitreous tag which is shaped like a bird which is sitting on top.
Yes.
But we really don't use our creative minds we are so engrossed with our clinical findings and everything else that we really don't focus on these things. And these are the other things that really make ophthalmology and practice a bit interesting for everyone. And I congratulate you on picking it up and
Thank you,
presenting.
sir.
Very
Thank you
nice.
so much, sir.
I think that's why all the participants are young, Dr. Nishikant. They're using their imagination. We are all
So engrossed in the rest of the things. This beautiful things up.
Yeah. So just to add, madam, the previous month of Eye Journal, Eye Nature Journal, that was also having the cover page. If people can remember, that was also a chronic CSR submitted by, I think, Dr. Vignesh sir from Arvind Eye Hospital, TP Vignesh sir, Arvind Madurai. That was also a similar picture, but these are small birds. That was a big bird. In fact, the neck and the the face of the bird kind of thing. So that came in the cover page of Eye Journal. So what we want to impress upon the viewers over here is that, as our panel told very rightly, we must manage the patients, but at the same time we should open our creative brain so that we can get some good images, some prizes, and maybe a cover page image also. Great. So congratulations again, Dr. Manu Sharma. He wins 3,000 rupees and the certificate for this. So with this, we move to the first winner, the final image of this session, and really it is the final image. The final should be like a final, and you will see this image. So congratulations, Dr. Apurva Jadhav. She is a VR fellow in Chaitanya Eye Hospital, Trivandrum. I think Dr. Unni sir has left for some urgent work. So I will show you the image. Can you see the beautiful image? Raging forest fire. She has nicely captioned it. You can see it's like the forest fire. It is just growing, and this is taken. I will leave it to her. She will explain about this image. This is the description, the text she has given. So, Dr. Apurva, congratulations. Can you please describe this image?
Yes, good evening all. Thank you, sir. Yeah, thank you to the committee members also, and credits to our team also for capturing such a beautiful picture. Because Okta, taking a picture of Okta is really very difficult. So I'll just take half a minute to explain about this case. So this not young, old gentleman, 64-year-old. So he came for a routine evaluation, and hence his vision, both eyes were 6/9, and we saw color fundus photograph. Evidently, we could see all the neovascularization elsewhere. But then we went ahead and we captured this image on Okta. And this is how we got the image, and we can clearly see that there are beautiful networks, surrounding the CNP areas. And looking at this picture, two things came to my mind. One was the raging forest fire, which we could see on the top, how we can see from a helicopter from top how a raging forest fire is. And second is about the crab thing. You can also see crab, but I thought so that raging forest fire is a much better title, so I just kept this one. So coming to the Okta, I'll just mention about the measurements. It's a 29 mm by 12 mm slab measurement has been taken, and this is a vitreoretinal slab, as ma'am has mentioned, to always mention about the slab, which slab you are taking. So it's a vitreoretinal interface slab we've taken. Thank you so much.
No, Dr. Apurva, very nice description, but one important thing you have missed, the name of the machine, Interlight machine. How many of us were so yeah, you did not tell that.
Yes, no, yeah, Interlight, it is Interlight.
Interlight. And what was the diagnosis you told?
As a proliferative
diabetic
retinopathy.
Proliferative diabetes.
Yes.
So the other eye was also having similar.
Also similar picture. Yes, similar picture with a different pattern. And the very next day, patient actually underwent laser for both eyes. In 3 sittings, we've completed his laser, and the patient is stable right now.
Correct. So with 6/9 vision, suspecting this, taking in image,
yes.
taking it to the competition and winning, and the award first prize is great. So may I request the panel members to please comment or compliment or describe something about this image. Parveen ma'am,
can I ask a question here?
Yes, ma'am. Yes, ma'am.
No, did you say this was a vitreoretinal interface slab?
Yes, ma'am.
So I am a bit confused because you see so many blood vessels. Did you superimpose it on something else, or is it just a vitreoretinal interface?
It's the vitreoretinal interface, ma'am.
But in vitreoretinal interface, then you don't see so many the blood vessels, no, the superficial plexus, the retinal vessels. They will not be seen. This might be the superficial plexus slab.
we are actually still learning about the machine, and that's how I
Okay.
found out this thing. I'm really sorry if I've mentioned about it, but we are still learning about the machine. And while just going through the machine, this is how I just pictured this thing.
I think Apurva, it must be the retina composite map. It is showing the retina in all layers.
Yes.
All superficial, deep, everything put together. It must be the retina composite slab, which you get most of the
Standard OCT.
OCTAs, which combines all three slabs together.
Yeah, this is a composite.
Yeah, so you will be seeing all layers. You will be seeing which will be differentiated by different color coding, which you can see here: red, green, blue. That is why different color coding for different vessels and different slabs is.
Understood. Yes.
Tapas sir, Subhadra madam, any comments?
What it strikes me is the new blood vessels. You look they are at the junction of the vascular and avascular junction. So this reminds us that most of the vascular lesions usually they start at the avascular and vascular junction. You can see these new blood vessels are bordering that. And the second is compared to an invasive procedure like FFA, where the dye leakage, it blurs, the obscures the pattern of new blood vessels. But compared to that, here you can see the neovascular network clearly and its relation with the new blood vessels. So that's what strikes me. And again, congratulations for such a beautiful image.
I think we should also have a picture post laser, because see, as you rightly said, we are still learning this machine. I'm not familiar with it. So if you look at some of these new vessels, no, some of them have a white core. Now, does that mean that the fibrous tissue, it will not go away or it will contract? So I think as we learn, what do these color codes mean? Are these different types? And in a fundus photo, we have learned how to look for regressed new vessels. So regressed new vessels may not always go away, but they become more tight and they start getting some white tissue. Then we leave them alone. We don't keep on, like they'll not disappear. Some of them will disappear. Those who have early stage. So I think on these new technologies, we should learn how to look for active, partially active, regressed. So as we go about taking more pictures pre, post, we will learn some more things.
So great. So very nice points as we heard from all the panel over here. Any other points by anyone present over here? So good. Congratulations, Dr. Apurva. So she wins the first prize, 5,000 rupees. So it's party time over there in Chaitanya, Trivandrum. So I must thank all the panelists present over here with so many commitments. They have given their valuable time and very beautiful discussions. I am very sure that all the audience, because these sessions are recorded and these are all available in the VRSI website under the image committee heading. So all of the viewers, they can go through the recorded session. And I request all the senior people present over here and also watching on YouTube to please encourage the fellows, because all of us know that all are teachers, and please encourage your fellows and junior colleagues to submit images to the VRSI image competition. And it has been very simple, very automatic, and people can submit images very easily. And also again, congratulations to all the winners over here. Please keep submitting your images, and you are doing a great job over here. Also, I thank the VRSA image committee members, Dr. Naresh sir, Dr. Unni sir, Sangeet sir, and Manisha madam, and team sir, and all the EC members of VRSI. And last but not the least, in fact, the most important is the team Numeratech, especially Manjula madam, Prem Kumar, and their team, Sai sir. They are doing a great job. Without them, this the PPT and all would not have been possible. So, if there are no further comments or points,
Thanks, Chitranjan, for making it very interesting. Your moderation has helped us go through all the pictures and we enjoyed it. And of
Thank
course,
you.
multimedia team, excellent presentation that you have made for the day.
Yes.
Thank you.
Thank
Yes,
you.
ma'am. Thank you. Thank you, ma'am. So,
Thank you, Chitra. Thank you all.
thank you, everyone. Thank you, sir. Thank you. So with this, we'll call it a day and we'll stop the